So now we're going to switch to talking a bit about treatments. The message Shoba's been trying to give you all morning is doing the TAND checklist is not the end, it's the beginning. So what I'm going to tell you now is, yes, the TAND checklist is the beginning, and we need to go into treatments. For most of the treatments that we might consider, we actually don't yet have a strong evidence base. Over lunch, we were talking about evidence versus anecdote. And we're really keen to say to people, we try to recommend things that have an evidence. But in TSC, very few things actually have strong, clear evidence. But it's important for us, and both for parents and for us, to think, if somebody talks about snake oil, that's an anecdotal thing, and it might work for you, but it's also dangerous in some ways. Or when people talk about CBD oil, it might be good for something, but it might not. We don't know. So there's a difference between evidence that something works, evidence that something clearly doesn't work. There are things that we know are harmful, and then not yet having the evidence. And many of the things in TSC is in that not yet having the evidence group. That's why we just need to be careful. So, do you all remember the TAND umbrella? Okay, so can I test you? I want you to take your piece of paper and draw the umbrella for me. That's why you got a little book. Draw the umbrella and just the kind of the main headings. You don't need to remember all the bits underneath. And I'm going to come and check your umbrellas. All right? Not to embarrass you, just to see which ones you remembered. Mum's using her child as an excuse not to draw the umbrella. So this is just the umbrella with the number of different levels. I just want to see if you got the different levels. You joined in later, so we have to excuse you. You're excused. You can help me examine the umbrellas. Dad is drawing a beautiful umbrella. That's good, yes. He's a good artist. Now we need to see if he has the content. You can check with your friends if you want to, but you're not allowed to cheat by looking at the picture you took earlier. How many have you got? Good, good. But they're all correct. Is that a level or is that a component? That one goes there. Yeah. Okay. So how many have you got? Good. So attention is part of neuropsychological. Yeah. And it's not neurocognitive but neuropsychological. Yeah. Good. Pretty good. Yeah. Good. Good.
Psychosocial, neuropsychological.
So this is the difference between recognition and recall. It's one thing to say, yeah, that's familiar, and it's another to actually write it down, right?
Psychosocial, academic, neuropsychological, intellectual, psychiatric.
Cool. Right, let's show that umbrella. We have a new technician, that's good. So here they are. Just for the reminder, the TAND is the umbrella term, behavioral, and there's a whole range of possible behavioral challenges that we see in commonly seen TSC. Psychiatric, this with the neurodevelopmental disorders and anxiety and depression that are most common. Intellectual level, often see intellectual disability, but often these uneven profiles. Academically, reading, writing, spelling, maths. Neuropsychologically, a whole range of specific neuropsychological skills can be problematic. Dual tasking in particular, switching memory, all sorts of things. Cognitive flexibility, we didn't do that example, but cognitive flexibility is about the brain's ability, once you've done something and you realize it doesn't work, to switch. And often that looks like being very rigid if you keep trying the same thing and doing the same thing. And we often see that in people with TSC. And then the psychosocial level, which you all got. That's much more interesting, right? So, you remember TAND checklist, and that we use the TAND checklist to generate these 7 clusters. So what we're going to do now is just to think, oh, we're going to keep Mum very busy now. Sorry, Mum. Just don't want her eyes to get... She's going to get laser surgery. Okay. So, what we're going to do now is use, and you have your TAND checklists in front of you, just those clusters, just think a little bit. If we identify these symptoms, what might be a next step in terms of going towards intervention? And we'll say something about Scholastic, the hyperactive impulsive cluster, the dysregulated behavior cluster. I know that you're going to have a talk on management of behaviors that challenge, but I will just say a little bit about the cluster, and then mood and anxiety, and something about the autism spectrum cluster. So let's start with the Scholastic cluster. So if you look at your TAND checklists, item 6. So if you, as mum or dad, had checked any of those items, any of them is a marker or a risk for academic difficulties. And you'll remember I said almost 60% of people with TSC are at risk of having something in that box. So I would guess many of you tick that box too. So then the question and the challenge, and this is where Shobha and you guys can tell us, is if that is the problem, we need to find ways to support children in their learning in an academic setting. And I don't know how it works here. Oh, sorry, I should have, that's the wrong name. We actually, this is a slide that I used in Belfast a few weeks ago, and in some countries there are actually organizations that specifically, oh dear, yeah, we talked about the okay. Yeah. He has, mum and dad were saying that he struggles with swallowing of liquids. So solids are okay, but liquids are difficult. And I think so it would be important for that to be part of the comprehensive assessment of his physical test, because the risk, of course, for him would be aspiration. So not just after a seizure, but at any time as well. Yeah. And speech therapists and sometimes OcuHealth people and sometimes dietetics teams have very good skills at doing the assessment and at finding that. Yeah. Okay. So in some countries there are actually teams that support families to negotiate the educational system. That's what Fiona does. But how does that work here? How easy is it for you to get to ask an educational system to say, can you please assess my child? I think he's at risk or she's at risk. What extra help might we need? Maybe, why don't you just say something about that, Shobha?
India is full of such centers. Yes, will you all agree on that? There are many, many centers here where multidisciplinary team is very much available. आप सेंटर पे जाएंगे, फिर वो बोलेंगे कि ये असेसमेंट कराओ. So psychological से लेके occupational therapy, physiotherapy, the entire gamut. So it is actually quite easy to get these things. But I would say that's still available in big cities, right? In the rural areas, diagnosis ही नहीं है और multidisciplinary team तो है ही नहीं. So there is no assessment there. It's not available, right? Maybe a Pune or a Nasik maybe शायद होगा, but certainly not in maybe Surat or Ahmedabad तो होगा, but maybe very very remote cities में Ranchi for example, या पटना ये जगह में तो नहीं है. Ludhiana लीजिए, which is such a big city. So that is a challenge. In the sense there are many centers, but the second line cities and the rural areas, there is no diagnosis and there is no multidisciplinary team or assessment which is happening.
And so in a way, right. Yeah. Yeah. And so in a way, that in itself might be a challenge and an opportunity for you in India and for TS Alliance of India to think, we know most people are at risk. How do we prepare mums and dads? How do we train teachers about it? The American TS Alliance actually have a full-time educational member of staff, and she phones and talks to different education systems, helps people understand that she does training, so to help people access it. Kids spend half of their life in school, and so if we can find the right sort of support for them to access education. People often say they're so desperate for their children to go to a mainstream school rather than a special school. My answer is, I think it's important that a child should have their educational opportunities in an environment that meets their educational needs. So the most appropriate educational environment. I cannot tell you what the most appropriate educational environment will be for your child. That depends on their profile and available resources in your setting. For some it may be in a mainstream school, for some it may be in a different environment. It's about they're finding the right place. Because if a child is in a place that's pitched too high, i.e., let's say they have significant learning challenges or neuropsychological issues, and constantly the expectation is very, very high, that often in itself leads to secondary deficits such as anxiety, distress, aggression, etc. So it's about finding the right pitch. Nobody can tell you what that should be. It's about finding and looking and matching. But I think people like Shobha and the team, you're an education expert, can be really helpful at thinking through options. And my practical tip always to mums and dads is go to the possible schools if at all possible. You will feel what will feel like a good place for your child. I think there's nothing worse than feeling your child is not in the right environment, because that in itself brings challenges. So that's just a starting way to think, how do we find about a way to measure these things? It's different in different settings. Sadly, in most educational settings, you have to show that you failed before you can actually get support. That's terrible. But that's the reality of our systems. But in our case, we can say, we know that there's a significant chance that my child will have special educational needs, and therefore how can we preempt the need, the support required that might help us navigate the educational system. Okay. The second box, if you look item 3, and you have ticked, if you've ticked overactivity, restlessness, or impulsivity. Have any of you ticked those 3 or 2 of the 3? All 3, okay. So the moment we see that, it clearly, the hyperactive impulsive cluster, what it tells us, it's very common, and in many people with TSC we see hyperactivity, impulsivity. And we see it, do you remember when we talked earlier about it links with intellectual ability? Yes, if you have intellectual disability, you are more likely to have these challenges, but across the intellectual ability range, even in people with completely normal intellectual ability, we see at least a third of them have significant overactivity, impulsivity, and restlessness. And even when they don't meet criteria for ADHD, it might still cause significant challenges, because hyperactivity, impulsivity is a risk marker for lots of other things, and I will talk about that. I will give the example in the next little section. But if you've ticked those boxes, if those are the things that you are concerned about, what we're recommending is a child, if they haven't had it, should have a workup for ADHD. So the challenge, and we talked about that over lunch, challenge with TAND is there are many different professionals who will do some of these things. So in your country, it might be a pediatrician, a developmental pediatrician, a psychiatrist. These are typically the people who do these sorts of assessments. Sometimes it has a psychologist as well, etc. But this is what we then recommend if those are the boxes you ticked. If a child has mild to moderate ADHD, then there are all sorts of techniques in terms of helping them in classroom, in school, improving their attentional skills, etc., without the need for medications. If it is severe ADHD, then we recommend that they have stimulant medications plus all these other things. How many people in this country, how easy is it to access ADHD assessments, medications if needed? Is that a challenge? Is that relatively straightforward? Cities, different in other places. Okay, so the challenge might be about being more rural or less access. And if it's a problem about private versus not private, that's a problem in many parts of the world as well. But that's the recommendation, because you should seek it. Often people are scared about stimulant medications in TSC because there's this theoretical worry that it might lower the seizure threshold. But actually, there's no evidence to support that in TSC. We have, and I have, and many other people have prescribed stimulant medications in TSC, and it really doesn't worsen seizure control. I've never seen worsening of seizure control. So sometimes people say, we can't use these medications. We can, we just need to be mindful of the impact on the kidney and other kinds of, and the heart if they have heart issues. Yep. Yep. So clonidine is one of the second-line treatments for ADHD. It is a useful treatment. Clonidine is also a useful medication for the combination of ADHD and aggressive behaviors. It's sometimes used by people. Clonidine, like stimulants, like methylphenidate, just has a risk of impact on cardiac function. So in TSC, because we know there's a risk, it's about doing an ECG, looking at it, monitoring it, being careful and being sure about it. But it's not a contraindication for those sorts of medications. And the risk in TSC, I did a study in the UK many years ago. We went through the country, looked for kids, we diagnosed them. 55% of them met criteria for ADHD. One of them actually had a diagnosis before us and had treatment. So that's been the dilemma. Most of the time, they simply don't, people don't think of the diagnosis, and then they don't think of the treatment. So that's the main story here about actually pursuing ADHD. As I say, I think there may be more to it than just ADHD, given that our cluster has attention somewhere else. But I think this is certainly the key recommendation at the moment about that particular cluster. And then when children, the stimulant medication doesn't make everything go away, but it can help them access learning. And if a child is able to sit for long enough to focus, to learn, that's what you want. And that's the gains that we're hoping to see. And that's when we would say to the local experts, the pediatricians, the psychiatrists, use the treatment guidelines that you have in your country to consider this child for treatment. There are European guidelines, international guidelines, etc. So that's the evidence, even though we don't have evidence inside TSC for these conditions yet. Okay. Dysregulated behaviors. So this is if you've ticked aggression or temper tantrums. How many of you ticked aggression or temper tantrums? Yeah, it's usually most people at some point in their life. Sometimes people ask me, is that the same as meltdowns? Do people use the term meltdown here? So in the autism community, people often use the term meltdown. It doesn't matter what the word is you use. We're talking about when behaviors become dysregulated. Sudden explosive outbursts, suddenly kicking or shouting, suddenly screaming, suddenly harming yourself. That's the group. And it's a very specific group, and it's a major challenge for families to have this sort of dysregulated behavior group. You will have a talk specifically on behaviors that challenge in a minute, but I just want to give you a little bit of background that hopefully will connect with your presentation in that regard. I showed you this graph for hyperactivity. The amazing thing in TSC is that aggression, tantrums, etc., we see across all intellectual abilities. So you can see here, even people with completely normal intellectual ability, 50-odd% show significant aggression and tantrums. So everybody is at risk of it. And that's a really important differentiation. The drivers may be slightly different, but many people have it. And management is a big problem. This is the most common question when families are referred to me. This is the question people ask me. What medications will change this behavior? What do you think do I say to people? What do you think is my answer when they ask me, what medication will manage this behavior? No medication. Well, it's a good answer, but it's not my answer. Combination of medication and intervention. No, that's not my answer either. My answer is, you are asking me the wrong question. My answer to them is, this is what you should ask me. You should ask me, what is the meaning, what is the function of the behavior? Because anger, aggression, tantrums, self-injury might have many, many different pathways that lead to that. And that's the challenge. Who wants to just shout out a few examples? What might be the drivers to aggression in your child? So a sensory thing? Sensory, yeah. All the range of sensory things, good. Anxiety is a great driver. So sleep-related, so biological things, yeah. Yeah, so communication issues. Others? Any of those, any of those. So here are some that I wrote down. And you've got some of them. Inability to communicate. So if you can't express, and it's not just in minimally verbal people, it's also in people who have language, but they struggle to get that right thing out. That could be manifest as an aggressive outburst or a tantrum. Sometimes as people have very ritualistic or repetitive behaviors, and often when we stop that, that might be the trigger for an aggressive outburst, because sometimes for some people it's actually a self-soothing or an anxiety-reducing thing. Sometimes even when people hate themselves, that's an anxiety-reducing behavior. Do you remember I talked about hyperactivity, impulsivity? That is a driver. That's in itself. If your fuse is short, that could be the trigger that drives your aggression. Which means if that's it, if this is the driver, if we treat this stream, that might in itself improve that part. Here's your example, Shoba, sensory. And so many people with and without autism have sensory, either sensitivities or drivers, and so on. Are you all familiar with the differentiation between general sensitivity and idiosyncratic sensitivities? Do you know what I mean when I say idiosyncratic sensitivity? So general sensitivity, and this is particularly in autism, but in other things, many of us have them. There's nothing that's unique to people with disorders. Many people have a general sensitivity to things. So sounds are a bit loud, or light is just too bright, or whatever. But then, and that usually makes people feel anxious if they hear a car noise, or the vacuum cleaner, or the toilet flushing, etc. Anxiety. Idiosyncratic stimuli are particular things that you can identify as a trigger for a response. And particularly in autism, but outside it too, we can often find specific triggers. So the sound of a baby crying, the sound of crunchy paper, that's one that drives me crazy. The sound of sudden explosive sounds like applause or or even sneezing for some people. So that can be a trigger, and when it's an idiosyncratic response, it's usually an aggressive response. So you might see a sudden outburst in response to that trigger. So tiny things can be the drivers of these things. Low mood, you said anxiety, so certainly anxiety and low mood. If you're, and it sounds counterintuitive, but a person who has a depressed mood or anxiety can manifest as aggression, and then we think it's an externalizing thing, but it might in fact be driven by that. Attention seeking, people often talk about attention seeking. Very often you would go to practitioners who say, oh, you should just ignore it. Now, if it's attention seeking, you're going to ignore it. But that's the only occasion you're going to ignore it, because there's another one called demand escape, or escape of demand. So let's imagine your daughter has significant problems with her maths. You're trying to get her to do the maths. She has a big temper tantrum, and you say to her, go to your room. Then you have helped her to escape the demand, because now she doesn't have to do the maths. Okay? So you can see that's kind of the opposite of this one. So we need to be very careful to understand what is the function. And in TSC, this is another really important one, pain and discomfort. There are so many things that can give us pain and discomfort when we have TSC. Auras of seizures, the medications, side effects, kidney things, headaches, whatever. And not always can people communicate that, and sometimes that is manifested as a behavioral, a dysregulated behavior. So you can see that there's not one intervention. I'm going to use a very different intervention for this one than I'm going to use for that one, than I'm going to use for this one, for instance. And that's the essence, and you will talk more about that in a minute. And it's different for different people. Mood and anxiety. So if you've ticked anxiety, depressed mood, shyness, or mood swings, how many of you who ticked that? Anybody tick those ones, or some of those? Yeah? The pattern in TSC is particularly from kind of early teens, 19, 11, 12 years, it becomes more prominent, more likely to have anxiety and depressive symptoms, and into adulthood. And once again, we see anxiety and depression across the ability spectrum. It's harder in somebody who has minimal language to pick up the anxiety and the depression, but it's there. So that's just a really useful thing to bear in mind. And in people who don't have comprehensive language, the clues we might get might be losing interest in things that they were previously interested in. Again, sudden changes in behavior like their sleep pattern or appetite, or starting to lose weight that they didn't lose before, or suddenly putting on weight. So those might be clues to anxiety and depression in people with intellectual disability. And here's the standard approach. So if it's mild or moderate, we can help people learn. There are many self-help techniques. There's kind of web-based programs, CBT-based interventions, other talking treatments. And then if it's moderate to severe, we use those talking treatments in combination with medications like SSRI. So SSRI is the selective serotonin reuptake inhibitors. Drugs like Prozac, I'm sure you get Prozac or whatever it's called here. Those are the sorts of medications that have evidence that in children and adults with severe anxiety or depression, it can improve symptoms. Never on its own, but with those other kind of possible treatments that we may have. I can't remember your name, gave a very nice, oh no, I'm catching her just as she's got something in her eye, was giving the example of just how powerful interventions like cognitive behavioral therapy or talking treatments can be for a range of conditions. And often people think, I can't use it in a child, or I can't use it in somebody who has intellectual disability. It's not true. The trick is for us to find the strategies to do it, but it's entirely doable. I don't know, is your eye still troubling you? Are you able to, with one bad eye, just say 2 words about the example you gave us over lunch?
Basically, like that is, you all might be knowing about cognitive behavior therapy. So recently I did a small research with a group of kids on changing the behavior. We call it as a modified behavior technique, which has got published in ICPS conference, and I'm going to present next month in Paris. So basically, whenever the child comes with a certain issues like severe behaviors or tantrums, so what we need to do is we need to identify. So for example, even if it is a sensory issue or anything, if you know that this is a particular issue, like in my example, the child is having a issue with furry things and with white color. The child gets scared with a dog. The presence of white dog, or even a rabbit or a cat makes him very hyper and aggressive behavior. So we need to make the child to get acquainted with this. Initially, the child doesn't have adapted to that kind of thing. He had some bitter, either it could be the texture, I don't know what would be, why the child got so scared of the dog, or it could be a sensory issue, the tactile issue, or the auditory thing, because the dog barks and it might be irritating the kid. So what we have to do is, it's just like reinforcing the child with negative reinforcement and immediately the positive one. So what we have to make the child comfortable wherever it is possible, in a quiet, calm place. So show the picture of it, and when the child starts crying or aggressive, when the child starts showing the aggression, immediately replace that with something positive. Ask what child is good at, whether he likes the music or any chips or chocolate, whatever he likes. His favorite thing has to be like immediately one exposure of that, and the second thing with this. So over a period of time, the child will get adapted to it. So then one behavior we are trying to modify with in a positive way. So that really helped many kids in coming like over the sound thing, whichever is usually kids get in autism, like the sensory issue sound. Whenever there is a band or Bharat kind of is going on, like the child will get throws tantrum, or even in summer especially, because of the heat also the child will displays this self-injurious behavior. For that also we can replace with this kind of thing. So sending him, keeping him in a hot place, and immediately taking him to the bath, giving a shower. So this has helped many parents actually. So these are the 2 examples I can give. You're trying to adapt the kid.
So that's a specific example of how talking and behavioral interventions can really help children shift in their behaviors, or adults as well. It applies to all of us. If it's something that's a fear or an anxiety, it's about exposing them to that thing, sometimes even for a fraction, and then longer and longer and longer, and then making them realize that it's okay. You know, we all have things we're scared of. We all get anxiety, but we do things anyway, and that makes us realize I can feel anxious and do it, and it's okay. It's when we start to avoid that then we develop that the fears become even more strong, or the anxiety becomes even more reinforced. So that's the principle. So I just thank you for giving that example. The message is there are things we can do about all these things. It's not always easy, but there are techniques and skills we can get to. Then the ASD one. So many of you know about the autism connection with TSC, and TSC is the genetic disorder most commonly associated with autism. About 40 to 50% of people with TSC meet criteria for ASD. And so this middle block of behavioral manifestations, self-injury, delayed onset of language, repeating words, eye contact, getting on with other people, repetitive behaviors, rigid behaviors, those are all the risk markers for ASD. So if you've ticked any of those, and the more of those you've ticked, the more likely the chances that your child may have an autism spectrum disorder. And you remember I showed you this slide at the beginning, that people tend to wait so long before a diagnosis is even considered in tuberous sclerosis. And that's not what we want. The other thing that's really important is even people who don't have autism, in TSC, social communication issues are so common. So we see many adults with TSC, for instance, and they say that they struggle with social relationships, they struggle with forming romantic relationships, or with people at work. They don't have to have autism for that, but there are all sorts of things that you can do in terms of helping people develop their communication skills, conversational skills, social interaction skills, that can be very, very helpful for them. But just going back to this issue of ASD and looking for it from early on, as I said, we want to try and catch it before 3 if we possibly can. The reason why we try and catch autism before 3 is none of you are speech and language therapists, are you? But you will know, how many of you, well, most of you are parents. A child at the age of 2, we can normally count how many words they have, typically developing. By 3, they have so many words that we can't count them anymore. So the age 2 to 3 is the time of most rapid language development, expressive language development. And so that's the time that we think the brain is kind of geared up to develop language. And that's why we want to try and catch kids with autism very early on, to try and shift the trajectory. And I often ask people in the TSC community, if I'm in the autism community and ask people about the red flags for autism, most people will know about it. How many of you know about the red flags for autism? Yes, you should. So some of you do. So the red flags for autism are they're not diagnoses for autism, but they are clues that if we see them, it's a bit like the TAND checklist. If we see them, the more of them we see, the more we should think, oh, I wonder if I should have my child evaluated for autism. So that's what it is. And I'm just going to show you the red flags, just as a reminder, because I think it may be that if in the TSC community we can help people think about red flags, and then if there are red flags, to seek a diagnosis and to seek intervention, we might actually reduce that 7 years to much younger. So if a child doesn't respond to their name by the age of 12 months, by 1 year, all of us, if I call your name, you tend to orient towards the person. That's very hardwired. That's a red flag if they don't. If they don't point at things by 14 months and say, look at that, look at that. It's called joint attention. Hey, mummy, look at that. Not because they want something, just to show interest. If they don't do any pretend play by 18 months, so that's, like cup and a saucer and drinking and pretend to drive a car, those kind of things. If they avoid eye contact, everybody always knows about the eye contact issue in autism. If they struggle to understand other people's feelings or to express their own. If they have delayed speech and language, that's the most common red flag for autism. Kids at the age of 2 who don't yet say any words. And that's usually the first thing that mums and dads are worried about. And then repeating words and phrases over and over. She's not the only one who's tired. She's just the one who's showing it because her response inhibition isn't so good yet, right? Next red flag, giving answers unrelated to questions. Now, I always say my medical students do that too. But the example in autism is if we're talking about something and you come up with something that's completely unrelated to that discussion. And a lovely example that I often give is a colleague of mine was working with a child. They were doing social skills training about, how to have a conversation. I say something, then you say something, and then I say something. And she was talking about her pets. And then the next moment, the child looked at her and he said to her, "What color is your lawnmower?" And so clearly, he was interested in lawnmowers, and he wanted to know about her lawnmower. That's good, but it didn't have anything to do with that conversation. So that's an example of this sort of unrelated. Getting very upset by minor routines. It's not unique to autism, but it's a red flag for autism. Sometimes it's just having to put on a jumper or having to do things 5 minutes later or 5 minutes earlier or something before something else that's different. Very particular interests, you know about this one. Hand flapping, so kind of very rapid flapping or twirling or tippy-toeing. And we've talked about this one already, the sensory, unusual sensory interest. So any of those are red flags. It doesn't mean that it's autism, but it means if you see 2, 3, 4, or 5 of them, you really should find out how can I get an assessment for ASD because my child might have it, and we know that there are things we can do to make it better. And that's exactly the same in TSC autism and non-TSC autism. Autism in TSC looks just like autism without TSC. And there are very few studies, and we're now beginning to do some intervention studies of the autistic characteristics in TSC. And the kids are really responding in the same way that children with autism are. And just this point, and just to kind of reinforce it, often people think that we can't actually cure, let me not use the word cure, treat the autistic characters. We can kind of work around it. But that's not true. We actually now have interventions that can work through the core deficits, that can teach children language, that can teach them turn-taking, that can teach them joint attention and teach them imitation. And those are then the core skills for social communication. And many studies around the world now can show, including some studies in India, that you can even train parents to teach children to do these things in a home situation. And then their language can improve, their intellectual abilities can improve, all their social skills, etc., can improve. So it can be profoundly helpful. You just need to find the right sort of targeted support. So that's the key thing. And the word we use is naturalistic developmental behavioral interventions. It's a big word, NDBI, but that's the kind of treatment approach to autism now in the global word. Let me just wrap up because I want to give our next speaker some time. As I've already said, where the field is going to. So when we meet next year or the year thereafter, whether it's in Delhi or Dehradun or Bangalore or Calcutta or Kerala, mTOR inhibitors to treat TAND. So that's where we're really thinking, do these things make a difference? Not just to the brain and the seizures and the kidney, but also to TAND. We're very interested in other medications for TAND because, as I've said, we don't have evidence. We're saying use the evidence outside TSC, but it may be that these things work as well or differently in people with TSC because we know the biology in TSC is a little bit different. We're also very interested in some people are starting to do some non-pharmacological, in other words, talking treatments for TAND because we need to build up the evidence base. As I've said, we don't really have that evidence base. I mentioned the TAND toolkit, which is basic next step things that we want to give mums and dads and grandparents that they can do at home and in the community to help kids develop and get to the next step. And then the question, which is very hot topic in tuberous sclerosis, is how early can we start? Certainly, we know we should start as soon as we see anything that's a problem. As soon as you're worried, we should start. Some people are saying, can we start even before we're worried? So can we give preventative treatments for seizures, for instance? Can we give preventative treatments for TAND? Can we give people mTOR inhibitors at birth? And then some people are saying, oh, but we can maybe diagnose it while it's still in a fetal ultrasound. Can I then start to use an mTOR inhibitor while my child's still inside me? the earlier we go, the more worried I get, because the risk of side effects might be bigger too. But you can see that's what people are trying to understand in the field. So there are some studies that now give preemptive treatment, so before problems start, with vigabatrin, for instance, several preemptive treatments with mTOR inhibitors. I don't think it's going to make things go away. The early evidence doesn't suggest that. So the key message, I think, for us at the moment is we know the risks, we know what to look for. The key thing that we can and should all do is to, the moment we see it, to identify it and to start with an intervention, because we know that that's going to make a difference. At the moment, not even that is happening. So before we jump to treating ADHD in utero, let's do the things when we see them. So that, I think that's just the kind of thing. And then, of course, people are, this concept of can we cure TSC? Many people use the word cure. I don't know what your thoughts are about cure. I think it's a very loaded term. In a way, if it means we want to optimize people's lives and outcomes, that's fine. If cure is about making something go away, I always worry that we're saying that people with TSC don't have value if they have problems. And that's not true, because each one and every of us bring and contribute to life and to world and to value. Interestingly, if we look in disability studies, families who live with disabilities, if we ask them to list the kind of pluses and minuses of living with a disability, people typically list more positives than negatives. It strengthens family resilience, it gives them new ways to think about life, it makes them more empathetic to family members and other people in society, it makes them more likely to be socially minded. So with the hardship of disability also comes many, many positive aspects, and I think that's why I'm just hesitant about the word cure. Many of you know I have a brother who has autism and intellectual disability. He doesn't have TSC, he has Down syndrome, Down's intellectual disability, autism. So even from personal experience, that's my firm belief system that each and every one of us bring great value to society, and it's about us finding and making a space for each person. So just some final words for me, and then we'll move over, and we'll probably do general discussion at the end, right? Make sure each of you, this is a prescription, find your personal pleasures. Sometimes mums and dads run around so much that you forget to think about the things that give you pleasure. So if it's movies or running or painting or singing, make sure you find those for your family members as well. Do them. Don't forget them. Okay? Sometimes we put things on the side and say, one day I'll get back to it. Don't wait for that. You also need to take your little break and your little pit stop. But also find some shared pleasures. Often, particularly when kids have autism or intellectual disability, it's hard for us to find something that we know we enjoy doing with them. But find those things and do them, because there's nothing more rewarding than having shared pleasure, even if it's for a few seconds or a few minutes per day, with your family member. There's very nice research actually now about just kind of resilience building and strengthening, even communication building in shared pleasure activities for people. And so it really is about find the things that motivate them. Often people say to me, I cannot access my child with autism or with TSC. All of us have things that motivate us. If nothing else, it's probably a cell phone or a smartphone on their lap, as I can see there in the back. Most people are motivated by food or things they can eat or drink. Find those things and use those as a way of accessing and connecting with family members. It works. They might not want to do what you want to do, but if you do it the other way around, you're very likely to get communication, shared pleasures, and those sorts of things. I'm going to say thank you for the moment, but this is a pause because we're going to have another talk. And I don't know if you've brought